the first time daily digital practice from radiological planning to implant prosthetics. So thank you very much for this invitation to be a part of your education program, now worldwide via web. And my topic is digitalization in modern implantology and also maxillofacial surgery. So we in our Nilius clinic have an all-in-one concept. That means that we have all dental and orthodontic treatments and also maxillofacial procedures under one roof. And for this, we have two different teams. We have a dental and maxillofacial team, as you can see above. We're now here with 4 doctors, and we have different lab technicians that you can see downstairs. So it's a combination of a team in-house and then a lab just over the road, not far away. I will give you some expectations. So where are we now in digitalization, and what is the standard now, and maybe some hints where we can go in future in our daily practice. And I will show you a case report, and then I will say maybe what can digital do better in this case, and I will do some reflections of what is better, or is it okay to do it like this. So why digitalization? Well, there are patients, they are increasingly informed, are very educated, or have informed themselves via the internet about the upcoming or interventions. Together with them, we make the decision for a treatment option. On the other hand, there are doctors, we, you, me, here, and we need this form of digitalization on one hand for training, such as e-learning, or for tutorials or webinars like this, or generally for the lessons. And however, we also use digitalization in daily use for the treatment plan. So what we need is predictability and reproducibility results. These are some of my patients I want to show you. Maybe not all of this I will show you, but a lot. And you will see 11 case reports, and we will discuss. Maybe we can do it later. And definitely one of these patients is a fake patient, and you can maybe estimate or imagination which one this is in our maxillofacial department. Case 1. So let's first go to the analog implantation and augmentation in the conventional lab. This is what we do today. We have a defect in the incisor. It was root resected. As you can see here, there is root resorption as well on the natural root. The buccal bone structure is defect, and we put in the implant. Then we make an augmentation, and sometimes we do an immediate loading, but in this case not. It's a 1-wall defect, so we have 3 walls as well for stabilization, but normally I don't go this way. We wait at least for 3 to 6 months, and after doing a radiography, we have a glue technique. It's a special kind of glass technique that was developed by a company, and we have titanium base, and as you can see here, and a glass ceramic for abutment is a screwed one, and then we put on our glue. The following pictures show the exposure as well as the analog impression using Impregom. So ceramic structure and titanium base were used for this, and the provisional initially supply, and after 3 months the final crown supply. This is a success for the patient. She came later. The patient asked for a new bridge on the right upper side. For this purpose, 2 implants were placed in position of the right upper canine tooth, as well as in the area of the right upper molar. In position of the right upper canine, the bone ratios were sufficient. In the area of the upper molar, we had to do a sinus lifting. We normally make a lateral window. Maybe there's a standard. After a healing period of 6 months, we can load these, and we prepared 4 single crowns, as you can see in the next picture. The patient, you can see on the right side, the crown ratio was not so ideal, so she asked for a better solution, and this, you can see on the right side, is the final solution. So What can digital do in this case better? Maybe we should have done the bone augmentation beforehand and then the implantation, or we have to digitalize the lab procedure. Here's one case. 3D image technology has been refined. I told about this topic when I was last time in Aleppo, and we call this bone veneers, as you can see here. This is from allogeneic bone fixed to the residual bone using a minimal invasive procedure. Normally, after a healing period of 6 months, it can be placed in the re-established bones. The prerequisite for an aesthetic design of implanted anterior teeth is therefore the reconstruction of the local bone. And according to the concept of backward planning, first bone parts are reconstructed and then inverted, the minimally invasive implantation, and ultimately, as third, the prosthetic restoration of the anterior teeth can be planned. So in one step. All this can easily be planned digitally before bone reconstruction. We can speak of a complete backward planning, or yes, we call it advanced backward planning in my words. So we have to consider that maybe there is a bone resorption up to 10 to 15%. I'm just on the way to publish some results from the last 7 years, almost 7 years. And there is a small resorption of this bone, and this maybe can be cause problems later. So bone shields for avoiding the bone resorption may be in future one possibility. We follow as a prosthetic workflow. That means the scan first, then the digital modeling, the data matching, the planning, the CAD/CAM reconstruction, the rapid prototyping. Maybe I can, let me go back here. The CNC milling, seventh, the model production, the finishing. This is procedure, the oral prosthetic fixation, the final, as a final point. So it is also possible to go directly to the oral cavity for scanning. This is almost standard to avoid some casts. So this is a final restoration. Here on the left side, you can see the final restoration. This is before. I think it's a good result from bridge to crown in the aesthetic zone. So digitalization concept. When we started almost in 1985, 1990 with digitalization concepts to make a very precise surgery. And what we used in that time, in my time when I was at the clinic, it was called stereotaxy or satellite navigation. There are some robotic systems also available on the market. Maybe you go also with this. We figured out that it's normally for maxillofacial surgery. And when you go with an oral splint, as you can see on the next page, we have accuracy when we do operation in the viscerocranium and the facial part, around about 1 millimeter precision or accuracy. When you go to the skull base to remove some tumors, you have more, 1.1 millimeter of accuracy. And when you go to the neurocranium for neurosurgery, you have up to 2 millimeters, 15 centimeters far away from the oral splint. Normally, we use this for maxillofacial surgery or for skull-based surgery. I will show you one case. This is an orbital reconstruction. This is not for dental normally, but we can do a mirroring. You can do simulation with the systems, and finally you do the operation and you can reconstruct the orbital floor. Maybe there are some maxillofacial surgeons as well here in the auditorium. This is only to know. But finally, what we got in dentistry is our guided templates. And we use guided templates since almost 20 years. Here's one case, a typical case, missing teeth. Sorry for ortho. This is a 36-year-old female patient. A loss of the molars had entered the left lower jaw. Due to long-term tooth loss, there was a great bone resorption. The patient wanted a minimal invasive procedure without augmentation. And this was the hour for navigation systems. You can see a CBCT or a CT in former years. And finally, this is the backward planning. You can see the nerve. And finally, you do the operation beside the nerve. And what you can ask yourself is, what might be the right implant in this case? Is it a big one? Is it a small one? What are the threads? Are the cutting edges? Or is it a parallel wall implant? And there are some good new inventions from Megagem that you have a very small body and a big cutting edge thread that is going directly through the bone. Here you can see, according to different D1 to D4 classifications, you can have a very small core here on the right side, or a bigger corp here on this side with less cutting edges. This is the final CT after planning. Planning is almost 1-to-1 without big differences, and the final restoration here. On the right side, these are the old metal crowns. I think it was in Ukraine made, and these are the cemented crowns on abutments. So finally, guided templates are the goal in dental implantology and in oral surgery. And here's one case. Next case, where we do extraction, implantation, and prosthetic with a cemented crown. This shows one or more different complications that can be when you're not so when you're a surgeon only and not interested in prosthetics. So this is the case. You can see this is the upper left incisor in a good condition, and this is a root resected and tooth 1-1. So the central incisor. We decided to remove this one and to place an implant immediately. Normally we use the natural crown that is molded, and we inserted it. When you use a natural crown, it's possible to etch and bond and to fix it onto the neighbor teeth 1-1 and 2-2. Here you can see the result. Implant is in place. Here you see the natural crown. And here you see a soft tissue movement because it had a small recession. And after a while, 3 months, we can make an open impression, an open tray impression. And finally, we have a cemented crown on an abutment. And this was before on the right side, was an annulated. And what you can see in the lower jaw, there is also a labial protruded incisor. But the patient doesn't want to have, or didn't want to have any orthodontic treatment before, so we decided to insert a crown in a better condition and lip supported position. She was fine. The final crown was okay. She's smiling, but what can digital do better in these cases? So first of all, we can do a guided planning and guided implantation, and we can do a prosthetic backward planning, and we can try to have a screwed crown and not a cemented crown, because we know about the peri-implant infections made of cemento. And we can do an immediate loading maybe. So this is a case. This is intraoral scan for a full digital workflow. This is the CBCT, and then we mix CBCT and intraoral scan data matching. Getting the DICOM data, have a software, have an intraoral scanning, have a planning tool, have a doctor to improve and to approve the planning, design the model, design the crown, make template, you print, and not you don't cast. You have a printed row of teeth. Then you have this guided surgery template, and finally you do the operation what you planned, and finally we hope you have a smile of a patient. To do so, you have to decide what is the right implant. So is it this one? Is it a small one? What about the threads? What about the bone condition? And then you can estimate what might be the best implant to this in this case. You do the planning and the backward planning. Go over this. I normally talk to my lab technician, and he's doing all the things behind me, and the only thing he's telling me, look, what kind of implant do we want to have in this situation? I say, look at this got thread and so on. And he says, is it the right position? Is it possible to have a cemented crown or not? And I say, that's okay, maybe we can do it like this. These are the lab procedures for model printing. Again, then we have digital workflow made by our lab technician with printing. And finally, on the printed model, we also print the template for guided surgery. Here you can see, and this is a prefabricated crown before extraction of this infected and broken root. The only thing you have to do is to make the operation and to hope that the crown is in the right position, or the implant is in the right position in all the 3 dimensions, in the X, Y, and Z dimension. So, situation intraorally, implantation. Here you can see the resected root. I normally, when I have an infection of a root canal filling in the apical part, I have to remove this foreign body, and when you do so, you can see the apex of my drilling, and this is the defect with those apical in the bone. And then you put in the implant, have a final check for the Newton centimeters for the force, and then you can, if this is less than 30 or 35, you don't have to load these implants, but in this case it was possible. So it's the decision is made by you, what kind of implant you use, and then you can say it's possible for loading or it's not possible. I normally told my patients when I do the pre-op discussion, there is a big possibility to get it, almost 90%, but in case we will not reach the sufficient force of the implant in the bone, I will do it the other way. But in this case, it worked quite well. We make bone augmentation with particles, max graft, and then we have a soft tissue improvement. Here, this is PRGF, soft tissue membrane. And here you can see this is the root filling material that was on the apex. This is before implantation, and this is with the implant and a mount to cover the screw, and this is the final restoration. I cut it off, so settle on difficult and you keep 100 away. So make it easy, and then you can go like this. I will show you the next case. This is one patient who had already one implant. It was not inserted in the best way to say in these words, but he decided to have implants in the upper jaw. And now is my question, because of his age, he preferred minimally invasive procedure. And the orthopantomographic image showed a reduced bone supply due to the dilated maxillary sinus on the left side. And my question now is to you, what do you decide, or when do you decide? Do you need augmentation or non-augmentation? Normally, we have a DVT or a cone beam CT, and the residual bone height was up to 6 millimeters. The rest of the bone cavity and the position of the tooth to 4 was still sufficient for a normal long implant, and consequently, this more accurate diagnosis allowed the selection of a suitable implant body. So the implant you use normally, you have to decide by yourself. So, but what is the right implantation for this situation? Who decides? Is it the company that is supporting you? Maybe it's the box, the implant box you have in your operation theater. Or maybe it's better to have a sinus lifting procedure before. You have to decide which one of these nice implants you prefer. Is it the big fat one, or is it small and thin lady? So it's up to you. But that means you have to do augmentation. So if you put this one, you need augmentation. And maybe I will surprise you, but I decided to have the big one. So also in this case, digital volume tomography gives you more information. And here you can see this is a normal size implant, and this is a bigger implant. And there are some modern implants like the Enrich from Megagen, for example, where you reduce. You can see it here also in the tuber region. There is very, very, very spongy bone. It also gives you a primary stability. Here you can see next to the to the augmentation here, we put in also an Enrich implant. And normally we can use these implants for an immediate loading because the threads are so sharp, and it gives you a primary stability even when you have a D3 bone or D2 bone. What can digital do in this case even better? DVT allows for osteodensitometric evaluation, and here you can see when you make planning with a planning tool, an implant tool, you have a degree, what you can see here, about the condition of the bone. Is it D1, D2, D3, or D4 bone? And then you can decide what would be the best implant for the situation. I made this case in 2018, and the system gave me the information that it is better to put in some tapered forms implant in the lower jaw. I was a little bit decided because normally I prefer parallel wall implants in the lower jaw because it's very hard. But in this case, we decided to have the tapered form implants in the lower jaw, in the mandible. So, and we loaded immediately. So we had osteodensitometric evaluation beforehand, and we had an immediate loading. We were a little bit, we wanted to get how far we can go with digitalization, so we decided to have this bridge in one, like a horseshoe, but that gave some problems. Maybe this is not actually on the market, so maybe the scanner systems are not that great to have a full arch reconstruction in this moment. But it was 2018, and the scanner generations are even better. And after inserting, we inserted 2 more implants in the left and right lateral upper situation or region after augmentation, and then we made the scanning, and the final restoration is what you can see here on, I think, 10 implants. So what we use it for full arch reconstruction, the digitalization, the combination of intraoral scan and DVT and the data matching, and we can also use it for digital and orthodontic treatment. The template-based implantology is well known, but you can also use it for ortho. In this case, we have used navigation templates for an adolescent, and the present example shows a 12-year-old girl, or 13 almost, with a difficult tooth breakthrough, as well as a double Gemini teeth attachment of the upper incisors. So this is also possible, and maybe you know the program is called Dolphin, Blue Dolphin, where you can visualize your patient, what it is possible by palatal distraction, by Hyrex screws or transverse stretching devices or other orthodontic appliances that can produce by means of intraoral scanning or else by 3-dimensional radiography via STL file. The most young patients often have no artifacts because they do not have any radiographic problems with filling materials or amalgam or whatever. So it's quite good also in adolescents. And this is what we did. We used the template, and normally when we insert the implants, we made a guided biopsy. So after removal of the microforms, tooth from the palatal side, so minimally invasive temporary implant placement was performed by the palate, and we used this anchor pins for preparation of the hole for the very small orthodontic implants, as you can see here. And we used this because only milk teeth were here on the arch, so we used these implants for palatal destruction, and the navigation is possible using, I think there was a Nobel guide at that, in that time, and you can see the roots from the permanent teeth, and then you go directly between the roots. Here you can see the geminiforms, and this is the planning for the biopsy. So the temporary implants were used to apply this stretching apparatus. The not properly adjusted front teeth were ligated and attached to the apparatus, and the stretching apparatus was activated every day for 18 days. After 12 to 13 days, the upper jaw could be stretched transversely, and this is also one possibility for digitalization, what digitalization allows in adolescent. And here you can see the activation, and the upper side activated, this is not activated, and here the wires for, and this is edge and bond for the frontal tooth to put them in the right direction. And this is the control after 24 months. You can see there is also 1, 2, 3. The lateral canine was also put into the correct position. And finally, this is when she was 18 years old. So we have a follow-up up to 9 years in this case. So it's possible to have this combination. And well, combined planning is one of our focus here in our clinic. So we have orthodontic treatment from adolescent to the adults. And this is a singer from Germany who had, he wanted to look quite good on a TV show, but he had this situation, this dental situation. And what we did, we make a planning, a visualization, and animation, and for implantation. And finally, what we get is combined treatment. This is before and this is after. He's now a famous singer, whatever. So it was, but he's also a very shy patient. The nose was not operated by me, by the way. Okay, you can go more and more, and the people maybe who know my lectures, I start from easy case, and I mostly finish with more complicated cases. This is one more case with an oligodentee and microforms 1121, class 3 deformity, retromaxillary dyskinetic deformity, progeny, multiple non-development of the permanent teeth and microforms. And this is planned digitally in palatal distracted, augmented, hip grafted, orthognathic surgery, implanted, wired, and finally we got on the implants the final prosthetic crowns and bridges, yes, bridges as well. So this is possible. This is what we can do now. This is standard now. So it's reported in a rehabilitation. So this is current standard. The big question is now, what will bring the future in our dental offices or in our maxillofacial offices? I have some expectations. So the first thing that will change we have to avoid radiology or radiation from DVT. And this is possible by doing nuclear magnetic resonance, or dental MRT. And it is possible to have this data matched with intraoral scans. In the moment, it's very expensive to have this possibility. And I definitely know only university hospitals who have a dental NMR or nuclear magnetic resonance in the offices or in the university hospitals. Maybe it's in future times we will get this also, like we did, like we get the DVT in our daily clinic. One goal is that we can see the nerve and that we will not damage it, because our future navigational systems will detect the nerve by themselves. There is one publication from Jürchert and Freudelsberger from Germany, from Heidelberg University. They also make cephalometric analysis by MRE. And the next step will be to have data matched from MRT or magnetic resonance tomography with DVT. So to combine these both radiographic sources, and then we can go directly through different regions, tumors, maybe also dental microforms to remove it or make biopsies, or to make planning tools for implantology. So this is future matching of data. And we're just on the way to have the chances to implement also the intraoral scan. I will stop this and go far away. We have decision-making by osteodensitometric algorithms or intelligent radiological assistants. So now we have the lab technician ask me, what is the right implant? In future times, that will be automatically figured out by the system. They say, look, this is the correct implant for this bone. So maybe you have different boxes, but in future, we'll have a small box with one drill for one implant that is the best implant for the patient. And this might be a parallel wand, or this might be a big cutting edge or apex or sharp threads. Why? The next step, what we have to follow for the patient is, when you want to buy something in the internet, there is a click and buy button. And our patients, maybe in Germany, but maybe I think all worldwide, they want to have it immediately. They don't want to wait for weeks or months. So when you have the right implant for the right position, it is almost possible to have an immediate loading. So the one-click mentality allows us for single-step surgery, and digital backward planning allows for immediate prosthetics. That will change. That will be very fast now or in the future. But the future starts now. What you need is, I'll show you one case, DICOM data or NMR data. There's also DICOM data, backward planning or advanced backward planning, and the right protocol for the implantation. What we also need is predictability for what we're doing in future. And this is for advertisement. When you show the patient, look, we have an animation, like when you have this selfies modified on your smartphone. The patients come to you, especially in my case for facial plastic surgery, and say, look, I would like to have the nose in this shape, or I would like to have the teeth like this. I've seen Colin Firth or whatever, he has nice teeth, he has a very good smile. So we need concept, smile design, animation. It's very popular now in Germany. And when we have this Also, we have animation to show the patient what he can expect. Plastic surgery is a big market, and aesthetic dental crowns and bridges and aesthetics is also a growing market. And this is one of my last pictures. I think that we will, in future time, we will not have guided templates anymore. We will have a kind of mixed reality. And last week I was on a symposium in Hamburg. It was virtual, but it was participation. And there is a software solution now where we can do with HoloLens, estimating, talking to the patients, where are the problem, what is facial scanning, it's landmarking. The system is called Mixed Reality, and it's based on the DICOM data that were implemented. And the MicroLens and the HoloLens 2 is available since February this year, and they develop in 3 months steps new technologies to go through the patient, to go into the patient, to have the conversation, to show. And this is the last thing. I would like to thank you for this small step into the future, maybe some expectations, and I'm open now for the chat to answer some questions.
Okay. Thank you, Manfred, very much for your very nice lecture. Mixing future with reality and digital, it's very amazing, really. We have some questions from our colleagues.
Okay.
First question, how do you decide which implant system you will use in any case?
Well, first of all, I ask the patient, when you see a new patient and he has no implant, I decide what the best implant for his. We have almost 20 different boxes in our office, including zirconia implants and titanium implants. So I ask the patient. When there is a patient who has already implants, I normally stay in line with these with the company. When they have Megagen, for example, I insert Megagen. When they have other implant systems, normally I decide to go this way with the patient to reduce any problems in future times. So I have patients who have 4 or 5 different implants. Sometimes there are some studies. We are part of a multi-center study for some implants. Then I use it. I can offer my patients, well, look, this is maybe a very good chance for you to get an implant, because also implantology in Germany is very expensive. But normally it's a decision made individually. I wonder why artificial intelligence and when artificial intelligence is going into this market. Maybe this so it's individually, sorry to say this.
Which features should be in the immediate loading implant? What features should be in these implants that you are looking for immediate loading implants?
So the first is, when I have an implant and I also have one abutment I can use. So there are some implants you insert with a mount, and the mount is not, you cannot fix the mount on the implant. It's only for inserting. Mostly I try to use
Manfred, maybe you should stop sharing, then we can see your picture clear. Stop the fourth track.
Sorry, I didn't get it. Anas, one more.
Stop sharing. Stop sharing your lecture, then we can
okay.
See your hands. Okay.
No, now it's better. Okay.
Yeah.
So when I have this implant, for example, yeah, and I inserted this with my mount. Sometimes the mount, you can screw the mount, and so you have a rigid fixation in the implant. And then I use it for immediate loading, for example. And when I make extended backward planning, it's no problem. Then I put in the implant. The only thing I need is primary stability, and that depends on the bone quality and on the bone density, so quality D1 to D4. Sometimes it's not possible, so we try to do it.
Okay. Can we do matching data related to cephalometric or CBCT with DVT?
Yes, it's possible.
Okay. How do you find the accessibility of the patient between the traditional way of implantation and this with digital?
Well, you have to keep in mind, we try to have the standard like the university. So we are investigating, we have good contacts to the industry to have new ideas, and we have the advisory board meetings where we can develop new things in implantology. This is a very, very good thing what we can do. Well, maybe
I think it's easier for the patient to have everything with digital. He has the plan. He can expect. He can see what his expectation for the result.
Yeah, when you look into the psychology, there are patients who are only interested in the result. You say, look, we can get this, and they say, I don't want to know anything more. I trust. So please do it. Sometimes you have a professor for whatever physics, and he's very, very keen in having, can you show me the 3D, and can I have a look into my brain or into my jaw, and then you can explain. Well, there are some patients, very easy one, and some patients will say, look, I would like to have a maximum of predictability. And then you can say, okay, look, we make backward planning, we make this digitalization. Sometimes I make digitalization and also analog casts to say, look, we have also 200% of safety that we have the right model. For example, I made this one case with a full arch reconstruction on 10 implants. And I wanted to know by myself what is more precise. So when you have an analog impression, open impression, for example, on this 10 implants, and you make an intraoral scan, different scanner techniques there are, and then you can combine it and say, look, maybe what is more precise. Sometimes I do it when I want to make sure that it's very expensive to have a full arch on 10 implants with all single crowns, and you want to avoid any mistakes. So this is one decision. And there are some patients in Germany that have a very good insurance. And we say, look, sometimes you will be judged when you're not do the navigational templates, because the insurance know that when you have an extended backward planning, the problems later on are less. So when you do not do so, you will be judged because you could have avoided some problems. Maybe this is a typical German or maybe problem from Switzerland or from Europe, but there are some patients and some insurances and some lawyers who are very interested in these cases, and they are very good informed.
Very good. Have you tried these digital things with orthognathic surgery?
Yes.
Split and the details for the cases?
Yes, sometimes I do, yes.
Very interesting.
Yes, I know. And it's a good combination, well, because we do the orthodontic treatment as well. I say sometimes it's quite hard because when you're an orthodontic surgeon, you only make surgery. But when you see some cases where you cannot put the upper or the lower jaw in the right position because of the dentition. Then you get angry. And so we have some cases prepared, operated, and they are lucky. So
okay, and the last question. Do you think there is a limitation of for digital work, or it's really the future?
Well,
it's philosophy now.
I know, yeah. So this morning I wanted to, I had an operation, I had a tibia, a bone from the tibia for reconstruction of a destruction in the maxilla. And I tried to put on my HoloLens to have the scan of the leg and to find the right donor side of my bone. But so it is possible to have, or for example, a hip graft. You look to your HoloLens, for example, with this upper-class software, and you can have the right donor side, and then you can cut the edges of the augmentation you need for the maxilla, for example. This is maybe the next 10 years, 5 years.
Wow.
Yes, wow.
Okay, thanks very much for your time.
Well, it's not only dental, it's not only a dental thing, but I had to hurry up a little bit with my lectures, so sorry for this, for the wide screen of possibilities in maxillofacial surgery. I know stereotaxy is very, very special, but it's in our...
It was amazing. Thanks very much. Really, thanks very much. It was very amazing. Okay, thanks very much, and we hope to see you again in future.
Yeah, well, great.
I'll talk some words in Arabic now.
Okay.
طبعا بنتشكر دكتور مانفريد نيليوس على محاضرته الحلوة، وبتمنى تكون هيك كانت فيها بعض اللقطات المفيدة. بعتقد حكانا عن المستقبل إيش بيتضمن، وش قد ممكن يعيننا سواء كان بالجراحات الكبيرة أو بزرع الأسنان. بنتشكروا على هالمحاضرة، وطبعا ما بننسى إنه بكرة إن شاء الله رح تكون محاضرتنا عن CBCT، رح نحكي فيها إن شاء الله على بعض التفاصيل ونعرض بعض الحالات شو ممكن نستفيد من هالصور، نعرف الكونسيبت تبعها والفكرة تبعتها وشو ممكن نستفيد منها في تطبيقات طب الأسنان أو زراعة الأسنان بشكل خاص. يعطيكم العافية، وإن شاء الله بنلتقي فيكم بكرة بنفس الوقت الساعة 9:30 بتوقيت سوريا. يعطيكم العافية.